Hello, everyone. My name is Rich Tower, and I have the pleasure of moderating this webinar entitled COVID-19 and Pediatric Hematology-Oncology, Implications and Opportunities for the American Society of Pediatric Hematology-Oncology. I have a few housekeeping items before we get started. Please note that all participants have been muted for the presentation. I would like to direct your attention to the questions box on your screen. Please use this to ask any questions, which I will direct to the speakers at the end of our presentation. You can also use this area to let us know about any AV issues or technical difficulties that you are having during the presentation. This webinar is being recorded. For more information on COVID-19 and pediatric hematology-oncology, please visit the ASPHO COVID-19 resource page at www.aspho.org. Our speakers today are Dr. Andrew Kung, Chair of the Department of Pediatrics at Memorial Sloan Kettering Cancer Center in New York, New York. Dr. Stuart Goldman, Division Head of Hematology-Oncology, Neuro-Oncology, and Stem Cell Transplantation, and Professor of Pediatrics at Ann and Robert H. Lurie Children's Hospital of Chicago and Northwestern University Feinberg School of Medicine in Chicago, Illinois. Dr. Amy Geddes, Pediatric Hem-Onc BMT Fellowship Director and Professor of Pediatrics at University of Washington and Seattle Children's Hospital in Seattle, Washington, and Dr. Julie Panapinto, Professor of Pediatric Hematology at Medical College of Wisconsin, Children's Wisconsin, in Milwaukee, Wisconsin. The webinar format for today, each speaker will have time to go through a presentation on how COVID-19 has affected their institution and affected them in their roles. We tried to put together a diversity of roles in our panel today, which includes clinicians, administrators, educators, and researchers. After each speaker has had the opportunity to present, then the entire panel will be available to answer questions from webinar attendees. So please remember to submit your questions. Our first speaker is Dr. Kung. Dr. Kung, take it away.
Thank you, Richard, and thank you to all the participants. What I wanted to do was briefly share with you our experience at Memorial Sloan Kettering in terms of preparation for COVID-19, what we saw through the surge, and talk a little bit about where we are now on the backside of the peak. So this is just a depiction of the timeline in terms of when we first started experiencing the COVID-19 in New York City. And as depicted on this slide, we're showing here the testing as we performed within Memorial Sloan Kettering, juxtaposed with the testing that was done within the city of New York. And what is depicted here was that in early March, we began our preparations for the surge of COVID-19 cases. We actually saw our first patient with confirmed COVID-19 disease or viral testing in the middle of March, March 12th. And this graph represents the cumulative incidence of COVID-19 testing over the subsequent month. The data that I'm going to show you is a snapshot through the middle of April. And through the middle of April, we saw roughly 25 patients who tested positive within our practice, testing positive for COVID-19. That number has continued to increase, and we currently sit at approximately 30 COVID-19 positive patients. When we started preparing for the COVID-19 surge, one of the first things we did was to impanel a incident command committee within the Department of Pediatrics. And this was a group that was comprised of leadership, not only of the MD group, but also nursing, APPs, and administration. This group met every day, had daily huddles in terms of updates, and was responsible for communicating up to the hospital command system, as well as down to the troops on the ground. We began these huddles in early March and continued them throughout the course of the COVID-19 surge. We very early on took very aggressive means to mitigate volume with the goal of reducing inpatient as well as outpatient volume by at least 50%. We did so by delaying non-essential visits, those visits that were routine follow-up that could be delayed a few months without detriment. We, as most centers have, engaged telehealth measures to really be able to deliver care remotely. And then we were fortunate within our institution to also be able to take advantage of regional sites to bring care to patients closer to home. We decided to keep all clinical trials open, but on clinical trials to forego non-essential evaluations and to deal with these as prospective deviations to the trials. This is in line with what has been stated as policy by the cooperative groups nationally as well as institutionally. We instituted a patient testing and screening plan, which I'll review a little bit the results of. But importantly, because we are a pediatric practice, we also instituted screening and testing of caregivers, and I'll go through some of those results. And then finally, within this work stream, the real reason to reduce the volume of patients was not so much because we expected a large influx of COVID positive admissions. The experience from China, the experience from Italy was reassuring that that probably was not going to happen, but the reason to be able to reduce volume as aggressively as we did was really to be able to implement workforce protection measures. And so we changed the staffing structure to really try to minimize exposure. For example, our different services usually has a model where a different attending would be in clinic every single day. We went to a model instead where every service had the same attending in clinic throughout the whole week, and all other attendings worked from home. We did the staffing change not only for the MDs, but also for the APPs and trainees. And so trainees were taken off of elective rotations and all their outpatient rotations and work from home when possible. We transitioned to remote work, not only for the MDs and APPs, but also nursing, for example, clinical trials nurses or office practice nurses were able to transition to homework, as well as administrative support. These graphs show you some of the volume trends as a result of these mitigation measures. And so our main campus outpatient visits, what's shown in the blue is the historical data from 2019. And as you can see, we greatly diminished the volume in terms of the main campus outpatient visits. Part of that was spread to the regional sites where you see we had an increase in visits, but the most dramatic increase was clearly in the utilization of phone and telehealth visits, which really was bore the lion's share in terms of the ability to move to a remote approach. In terms of the results of our screening and testing measures, we started testing in all symptomatic patients or patients who had close exposures. We started testing all patients prior to admission, and we also tested all patients prior to deep sedation or anesthesia. This was based on the fact that anesthesia is a activity that poses great risk to the healthcare workers, and so even patients undergoing deep sedation where there was a risk of needing intubation, we tested all those patients as well. We tested all patients prior to chemotherapy, and initially we did end up delaying some chemotherapy awaiting resolution of COVID-19, but I'll come back to what we're currently doing. As I referred to before, we also tested accompanying caregivers. Any caregiver who was going to accompany the patient for inpatient admission, as well as those caregivers that were accompanying patients on multi-day chemotherapy regimens where they would be coming back to the clinic on a daily basis for, say, 3 to 5 days. We tested those caregivers as well. We were able to test symptomatic caregivers, and at the current time, we are retesting all caregivers as well as admitted patients every 72 hours. And the results of some of the testing is shown on the table on the left. And just to sort of summarize the take-home lessons from our screening and testing regimen, of patients who were symptomatic or were exposed to someone with proven COVID-19 disease, approximately a third or nearly 30% of all of those patients actually did test positive for COVID-19, so quite a substantial rate. Of all the asymptomatic patients who were tested before procedures or prior to admission for some other reason, for example, for chemotherapy, or tested prior to myelosuppressive chemotherapy, the asymptomatic carrier rate, if you would, for COVID-19 in the children was very low, only 2.5%. Now, this is in contrast to the caregivers. And so the caregivers of the patients who themselves were asymptomatic had a nearly 15% rate of testing positive for COVID-19. This number is very similar to the rate of COVID-19 positivity in women who present for delivery as reported out of Colombia. And so somewhere around 15% probably represented the prevalence of COVID-19 in the general public within New York City at the height of the surge. This finding, however, has significant implications in terms of infection control measures and is the reason that we continue to test caregivers in addition to patients. It's of interest that in half of the time where we found a caregiver to test positive, half the time the children never tested positive. And this speaks a little bit to the infectivity of COVID-19 in children, and it is probably diminished by comparison to adults. Now, in our patients who tested positive and who largely were undergoing immunosuppressive chemotherapy, almost all of the patients, 95%, actually had mild symptoms and were largely managed at home. There was only one patient who required admission for moderate symptoms and who needed only some supplemental oxygen for a few days. The child was not intubated. The other thing that we found in terms of the surveillance testing is that the infection control measures as related to the use of PPEs was highly protective. We did not see any evidence of spread from patients to healthcare workers that could be documented. The other interesting point that came out of the testing was that in our pediatric patients, we continued to see a very significant sex skewing in terms of those infected, such that 85% of the 20 patients that we reported on in this particular report were male. This was statistically significant, and this speaks a little bit to perhaps a sex bias even at the level of infection, since these boys clearly did not have the comorbidities that have been postulated to contribute to the increase in males with critical disease in adulthood. On the basis of these findings, we continue with this fairly aggressive screening and testing regimen, but we are no longer delaying chemotherapy, but instead are forging ahead with all scheduled chemotherapy in light of the fact that symptomatology was really quite limited in our patients. We continue to test caregivers and continue to screen caregivers. The rate of asymptomatic positivity in the caregivers has now dropped from 15% to something less than approximately 5%. And so this is probably, again, a reflection of the asymptomatic carrier rate, if you will, in the general public. So those are some of our current results. Now, in New York City, we have, as I said, surmounted the peak, and so we have very much started to reconstitute our clinical practice as we've seen the number of patients hospitalized for COVID-19 continuing to drop. Just wanted to spend 2 slides to really underscore what life looks like for us now and probably in the future. In this graph here, I'm showing you the number of outpatient visits per week. This upper purple line is the volume that we saw in 2019, and the bar graph on the bottom is in 2020, the current time. And what you can see is that through the later parts of March and early April, our volume was significantly diminished, but we've now reached a point in early May where our volume has largely returned to normal based on the type of volume that we saw in 2019. What is notable, however, is that 30% of that volume has been transitioned from inpatient visits to either telehealth visits or visits within our regional sites. And so I think that this will become and is the new normal that that we will be deploying in terms of our practice of pediatric oncology, a heightened use of telemedicine, as well as the use of regional sites. Our new patient volume is also depicted on this slide here, where this was our baseline volume prior to the surge. And as you can see, new patient volume did drop significantly through the end of March and April, but is now rapidly recovering back to our baseline numbers. But here too, even new patient visits has significantly skewed towards remote approaches for the initial visits. And so we think very much that this represents what the new normal will look like for all of us in pediatric oncology. And this is probably a reflection of the silver lining, if you would, from this crisis that many of us have wanted to be able to bring healthcare closer to patients in terms of where they live. And the crisis has really accelerated that. And I think that this is a trend that will continue forward even as we surpass the current COVID-19 crisis. So with that, thank you very much, and I'll turn it back over to you, Richard.
Thank you, Dr. Kung. Dr. Goldman, you're up next.
Well, thank you. And I hope to give a little bit more of a general overview of what's been happening here at Lurie Children's in Chicago. We're not quite over the peak yet in Chicago, but hopefully getting there very soon. You can move. So our initial experience as the pandemic and the shutdown in Chicago occurred, from the institution point of view, especially our division, was very much more of a provider pandemic. Early on, we had multiple exposures of our staff, staff to staff, staff to patients, and maybe even patients to staff. And at one point, we had about 40 of our staff, anywhere from point of service employees in the division to nurses, nurse practitioners, and physicians, who were either on quarantine or ill with COVID-19. And this created a kind of the pandemic had a panic almost experience for us, as we had shifting rules and recommendations. Initially, social distancing and careful hand washing was our initial recommendation from the institution, and quickly came to universal masking and further precautions. But one of the first lessons we learned was, how do we communicate these exposures to families, both doing that in a way that protects everyone's privacy, the privacy of those who are ill as staff and faculty, as well as giving information on what to do for families. So one of our first real lessons was, how do we effectively communicate? How do we make sure that families understand that new risk as their children have been exposed at the hospital? And how do we make sure that we keep families safe and confident in their ability to come to the hospital? And we did this with not only a personal phone call from either your closest caregiver, whether that be an APN or an attending, but we also followed up with letters and careful follow-up from our incident command that did have a COVID-19 task force that did our tracing and investigations. And though that task force sent with our medical legal department's graces a letter, it was really we decided it was the individual caregivers that the families are close to needed to share that information. That led to a shutdown basically of many of the programs in the hospital. And as Dr. Kung just explained, going to a very bare minimum staff and seeing patients. In fact, the institution ended up seeing about 25% of patients at the peak, or should I say the valley, of the beginning of this pandemic. But as we all know on this webinar, our patients can't necessarily stay home. So our next lesson was really figuring out, who can we put off? Who can we not cancel, but either change their appointments to telecalls or telemedicine? And how do we anticipate this will affect patient care? And so things such as the cancer predisposition program, we were able to do more immediately telemedicine. We were able to do more telecalls. Patients in our survivors clinic had to reassign their appointments. But unlike maybe the folks in Sloan Kettering, we were actually gearing up our telemedicine prior to this pandemic, but this acceleration we weren't quite ready for. And so this took a real coordinated effort to make sure that we all started getting privileged, and that the institution had the hardware to make sure that we could all do in a safe and HIPAA compliant manner to start to really ramp up our telemedicine. And our next lesson was balancing the patient's needs, their safety for the patient's family and staff, which actually has been an ongoing. And during the beginning of the pandemic here in Chicago, we developed a twice daily conference call with divisional leadership to figure out not just what we were going to do that week, but what we were going to do that day. And each of the section heads then reviewed all our appointments, who needed to be seen and who didn't. And then, of course, research on hold, our basic translational research, as the protective equipment necessary for the staff was going to take away that was needed in the animal labs and our research labs. Those labs had to shut down except for feeding cells and animals. And our clinical research as an institution was to go on hold, but we were able to say that our research is part of the standard of care. And again, with the same kind of caveats and ability to make sure that we didn't expose patients for PK sampling solely, we were able to maintain our clinical research for those that were most important. And this all requires new approaches to our care. Other questions that we came up with during this time was what to do with the fellows. You know, the shelter in place is for all essential personnel. Now, we consider fellows essential, but we decided that we didn't want to expose fellows who may be on service by being in the clinic. So we made strict rules that depended on your role at that time, whether you were the inpatient, one of the inpatient fellows, then you would not be having clinic that week. We tried to cohort to minimize the exposure, as our team rooms are very cramped and crowded and have multiple caregivers in there. So we tried to minimize. And we need to make sure that we were sensitive to educational changes with faculty involvement, resident students, and fellows, as our institution really had the medical students go on hiatus from seeing patients, and making sure the residents were less staff as well as our fellowship. And this will be discussed a little bit farther in the next area. But all during this time, as screening and testing picked up, I can tell you as of May 15th, Lurie Children's has tested 3,296 patients, and 305 of those patients as of last week were positive. Very interesting, we've done 2 surveillance screening of every inpatient unless the families denied us that privilege, and we were getting about a 2 to 5% positivity in asymptomatic patients. So this really left us to change our behaviors that all patients admitted are PUIs and are tested. We have not been routinely testing caregivers, but we have limited our caregivers to 1 parent only in less extreme circumstances. Currently, right now, Lurie Children's employees, as of last week, had 426 tested, 61 were positive, and we've now been able to decrease the staff positivity ranking. So I think one of the real lessons that we've learned here in our division has been about adjusting as quickly as possible to shifting rules, shifting recommendations. You know, as we've really geared up telemedicine, we're now working with private home care companies, as our institution does not own our own home care company, to make sure that we can subcontract so that we can get labs done at home. What about patients who need imaging? We've asked them to still continue to come to the hospital for those imaging, but can follow up those results on telemedicine. And we do know that many of our patients prefer telemedicine, and will they prefer to come back? Because I still personally believe seeing patients in person and the relationships that we can foster and the care that we can give are easier to continue in person. And as the division head, we wonder what about working from home, and how do you determine productivity when people are working from home? Our institution has now asked for a back to business as usual, but I believe that as many of our institutions around the country are now facing severe financial constraints from the pandemic, I believe each of our divisions has a responsibility to drive this back to normal by safety, not by financial responsibilities. Presently at Lurie Children's, 25% of our staff, the non-physician APN staff, is on a rolling furlough. And so as we're gearing back up, moving to about 50 to 70% of our past clinical visits, we're doing that with 25% less of our support staff. And so this has been another lesson for us. How do we continue to gear up at a time when we're actually having our staff being decreased? And this has really led to some real creativity that we need to use. Many of us get in the same habit of having the same person book our appointments, the same person help us to arrange for the exams we need. And now we have to go into much more of a group setting. So I think we're learning lots of lessons each and every day. And I think the main issue that we've seen here is flexibility and planning for the next day, not just for the next week, month, or year. So on that, I will turn this over to our next speaker.
So thank you, and thank you, ASPHO, for inviting me to participate in this webinar. I think when I was asked to talk about the impacts of COVID-19 on fellow education, and I think when navigating this response, as our previous speaker alluded to, it's important to balance not only patient care needs, but also fellow safety and fellow education. And that approach may vary depending on the current status of your institution. So the current status in Washington, just for context, is that the majority of the sick patients have been admitted to the adult hospitals, and that's meant that our fellows have not had to be redeployed. The impacts for the Children's Hospital have been mostly due, as in other talks, to limitations of PPE, limiting perhaps the number of patients the number of trainees that can be in the patient's room, or the number of trainees that can be in clinic. Holds on elective procedures and non-urgent visits, which have affected our patient volumes and those patients that are available for education. Requirements for social distancing, which is again limited the number of people that can be in clinic at any one time. We've also come up with a sort of rotating strategy for how many fellows are in clinic versus those who are doing telehealth. And budgetary impacts, which I think is going to be a major driver of changes and impacts in the coming year. Testing is available, and our routine, I won't dwell on, has been to test inpatients and preoperative visits, sick patients and sick staff, but we've not routinely been testing asymptomatic providers. And telehealth, which we had not previously been engaged in, has been rolled out in an accelerated fashion. So just breaking down the different areas of fellow education that have been impacted by COVID-19. Clinically, as I mentioned before, we've had reduced patient volumes. This has been disproportionately present in hematology as well as non-malignant transplant. Some of the volume in hematology is now being made up with telehealth. Limitations of PPE and social distancing requirements have limited the number of trainees that can be present in patient rooms. So is it the resident, is it the fellow, or is it the attending that does the exam that day? Also limiting the number of providers that can be in clinic. Again, we've come up with a strategy of rotating how many fellows are in clinic at any one time, with the remainder being working from home and participating in telehealth visits. There have been some logistical barriers to fellow participation in telehealth, one of which being precepting. This is a number of our attendings are also working off-site. There's just logistical difficulties in figuring out how to staff these remote visits, as well as the equipment and the private space in which to conduct these visits. All our didactics have been moved online, and for fellows with childcare needs, the university has provided childcare help, especially for those who need it to do clinical work. Regarding research, our second and third year fellows reports, they've been able to do about 50 to 75% of their scholarly work. Most fellows engaged in the master's program have seen their classes moved to be primarily online. Laboratory work has either been stopped or in some cases may be proceeding on a staggered schedule with researchers arranging their time so that there's not multiple people in the lab at any one time. Clinical research, unless it's involving an ongoing treatment trial, has largely been on hold. And many grant opportunities going forward, deadlines have been extended or on hold, as it's unclear whether some of the more private foundations will have funding available in the next year. Regarding wellness, the fellows, as all of the medical staff, have been greatly impacted by COVID-19. There's been a lot of fear and uncertainty around this situation. Some of our fellows may themselves be in high-risk categories or may have partners or family members in high-risk categories. They may have partners or family members who are also in the medical field or who might be unemployed because of effects of the virus. There's been a lot of uncertainty on how long this will be going on and how they can make future plans. Communication, I think, has varied from, in some cases, too little, but in many cases, too much. There's been days when I think they felt that there's so many emails around COVID every day that they barely have time to do anything else. And with our institution, as I suspect many others, there's various there's a hospital, there's a medical school, there's the various research institutes, all of which may be messaging about COVID-19 and not always saying exactly the same thing, and that's been confusing. The effects of social distancing have played a negative role in terms of mitigating work-related stress. I think it's obvious that fellows normally get a lot of support from their colleagues as well as friends and family, but also in navigating difficult work situations, painful conversations, difficult new diagnoses. It's been important that it's been an important change that the fellows may not have those good family relationships that they would have from in-person interactions to make those conversations easier to deal with. Budget questions for the remainder of the year and upcoming year, I think, will continue to have a reverberating impact from such minor things as planning graduations for our third years who've worked so hard, as well as grants and job opportunities in the next year. And then I expect some of these issues will be even more amplified for our new class of entering fellows, as they may not be able to have the relationships that will kind of cement their place in the community going forward with these restrictions and social distancing. For the future, we will have some more impacts upcoming. It is anticipated this year that we'll be having a virtual recruiting season. It's unclear if this will affect the number of people seeking a fellowship position. This already was on the decline last year, or how far people will be willing to go from home. Junior faculty for our graduating fellows will continue to be impacted regarding productivity as well as availability of grant funding. And many places are seeing hiring freezes, making job opportunities more difficult. We've been in the practice of supporting our fellows for a fourth year, and so are in hoping to secure continued funding for that to help cushion the effect of COVID on fellows at this vulnerable point in their career. And fellows that have children who are at home with difficulties obtaining childcare and children not being able to go to school, I think will continue to have some difficulties and have to be creative in terms of managing their work. So I think this has been kind of a sea change in terms of how we do things. We were hoping at the beginning that it would only last a couple of weeks, but I think as many have alluded to, this is now sort of a new normal, and we'll have to come up with some new strategies to not just survive, but thrive in this new environment. And with that, I'll give it over to the next speaker.
Hi, good afternoon, everyone, and thank you to ASPHO and Dr. Tower for the opportunity to share with you today some information about sickle cell disease and COVID-19 that is obtained from a registry of voluntary reporting by providers across the world. So as of May 15th, there were 172 cases of COVID and sickle cell disease reported to the registry with an average age of 29 years, close to 30 years. The majority of patients are hemoglobin SS genotype, and the majority of them report having had prior hospitalizations in the last 3 years for pain, with an actually pretty high rate that averages 8.5 hospitalizations per patient in the prior 3 years. Kidney disease is the most common comorbidity that we're seeing, with albuminuria, nephropathy, and decreased renal function reported. The illness is requiring hospitalization in the majority of patients reported. 71% require hospitalization and stay on average about a week. Pain is the most common symptom that's reported along with COVID, and interestingly is the only symptom reported in approximately 19% of patients. In addition, about 30% of patients are developing pneumonia, which is common with COVID and which is part of what we call acute chest syndrome in sickle cell disease. I have also displayed this figure down below of the age distribution of patients reported to the registry with sickle cell disease and COVID for everyone to see how it seems to be impacting our young adults and really over the age of 18 much more commonly than at the other two extremes. So pretty unusual to have it under the age of 10 and unusual to have it in our older age groups. So this table is illustrating the children 18 years of age and less, and those that are 19 years of age and older, showing you really remarkable similarities. So we have not done statistical analyses to look at this descriptive data, but we do see very few places where they seem to differ, and that is the use of NSAIDs seems to be more common in children, and the occurrence of pain in the prior 3 years seems to be much more common in our adults. In addition to the occurrence of central nervous system complications, in children we're seeing more silent stroke, and in adults more overt stroke. And then for hospitalizations, more adults seem to be requiring hospitalization and transfusions with their illness. This slide illustrates some characteristics of the patients who have died. So 14 patients have been reported to the registry that have died from the COVID-19 infection. And as you'll notice, similar to what was shown by the Memorial Sloan Kettering population, the males, so we actually have more females reported to the registry, but males, similar to the population in the US, are more likely to die with this disease, it appears. In addition, so the Chinese group very early on published COVID severity in children, so we adapted this for the registry, where mild symptoms are really just URI symptoms without any other difficulties, all the way to critical, which is multi-organ failure, shock, respiratory failure. So what I think is concerning us is that half of the deaths are not in critical patients and appear to most likely be somewhat sudden, because we do have some deaths in mild and moderate. So moderate means pneumonia, but no hypoxia. So certainly not necessarily a patient that at the time would appear to be very critical and must represent sudden death. So we hope to learn even more about deaths, but are a bit concerned about that finding. In addition, three of the deaths appear to have occurred outside of a hospitalization, one likely home and two likely emergency department deaths. So there's more information on how the recommendations for handling sickle cell disease and COVID and protection against COVID, and I'd advise you to go to the ASPHO website for resources in addition to the Sickle Cell Disease Association and others, which ASPHO does highlight and can lead you to. But in general, I think most of us, and you've heard this as a common theme, very quickly went to telehealth to protect our patients and their families from COVID and to allow them to self-isolate, as has been recommended. In addition, because many of us were worried about transfusions and a shortage of blood, we made plans to accommodate and conserve, but have pivoted back very quickly to, for instance, going back to erythrocytophoresis for those small numbers of patients that receive that for their chronic transfusions for stroke. But we're prepared to do simple transfusions and did for a couple of months on our small numbers here at the Medical College Children's of Wisconsin, but have not realized that blood shortage here. We all really believe hydroxyurea is protective at keeping patients out of the hospital, and worry that our patients who come to the hospital for complications are getting exposed to COVID. So we have advocated strongly where indicated that patients take this medication to prevent vaso-occlusive episodes. In addition, we were very liberal in making sure patients had supplies of all of their medications, including pain medications, which we are able to prescribe electronically through our system with the documentation through our virtual health. In addition, we have been able to provide workplace letters for patients and their parents to allow, we hope, for work from home or other accommodations to keep the families and patients safe during this time. And that is all I have, so I'll turn this back over to Dr. Tower and the rest of the panel.
Great, thank you very much, Julie. And thank you to all of our speakers. I thought those were great presentations. So now we're going to have the Q&A portion of the discussion today. So please, I want to remind you all to use the questions box to raise questions or make comments. So I'm going to read some of the questions here. Can Dr. Panapinto describe the inclusion criteria to be included in the SCD registry?
Sure, it's a COVID positivity, so understanding that the COVID testing is not 100% sensitive and specific, we decided very early on, modeled after the inflammatory bowel disease registry, to report cases only of COVID positive, in addition to long after enough the infection that the patient has recovered or had death.
Great, thank you. Dr. Kung, you've answered a few of these in the questions box, but just in case everybody hasn't been able to read that, what is the PPE protocol at Memorial Sloan Kettering? Universal for all patients given asymptomatic caregivers, or only for patients with known symptoms or known positive caregivers?
So for healthcare workers, we do have universal masking. Because we are testing patients and caregivers upon admission, and then also doing repeat testing every 72 hours while they're in the hospital, we do not do universal PPE on all patients, but rather all patients are subject to the universal droplet masking. And then PPE specifically for COVID-19 positive patient care is restricted to those patients that test positive.
Okay, great. It's like they're coming in fast here. Have any of the panelists had experience with COVID-associated multi-inflammatory syndrome in children in pediatric patients with oncologic or benign hematologic conditions? If so, curious about your experience regarding the incidence and severity. So again, question about the multi-system.
We have not seen that in our patient population. Obviously, within the press, within New York City, there have been, I think at this point, over 20 cases, but we have not seen it within our patients. I don't think that our sample size is large enough to draw any conclusions as to whether there's a protective effect of having cancer, but we have not seen it.
Are you testing for antibodies in your patients? So maybe speak a little bit more broadly to the antibody tests. Are you using any of these tests? If so, how are you using them?
So here at Children's of Wisconsin, for our sickle cell disease patients, Dr. Tower, we do not yet have the ability to run that test, but I do see that that may evolve over time.
We have deployed serology testing. We are testing both for IgG and IgM, and we are moving forward with testing all of our patients so that every patient has serology testing done, much as you would do for VZV or other infectious diseases.
So along the lines of testing, there are many different testing kits that are available, and there's been a lot of discussion in the news regarding false positives and false negative rates. How's your institution dealing with the variety of tests that are out there, especially as the FDA has temporarily suspended many of its rules relating to the approval process?
At Sloan Kettering, we went through a period of evaluation of the available tests. We are currently using the Abbott test, which we feel is highly specific. This is based not only on our own experience and validation experience, but also other medical centers, and that is our current approach.
Okay, great. Have guidelines changed regarding chemotherapy patients' admissions? So are you doing anything differently for your patients getting admitted for chemotherapy?
Within our program, we went through a period of time before we knew what the consequences of COVID-19 infection in our children would be, where we would delay any scheduled chemotherapy, not only inpatient but outpatient, for a period of time. We're now sufficiently comfortable with the mild symptomatology in our patients that we're proceeding with all scheduled chemotherapy, whether inpatient or outpatient.
To Dr. Panapinto, since only COVID positive cases are being reported to this registry, is the data for age distribution skewed, and how might that affect the outcomes data?
Sure. So I think in general, just as precautions, the data are likely very inherently skewed for many different reasons. Likely the biggest one being across the United States, there has not been widespread availability of testing. So we're not testing all comers or sort of a representative sample. Most likely these represent patients seeking healthcare and hospitalization, and they were tested because of that, right? So we do know that the data in that sense are skewed. But I do think that for whatever reason, we definitely are seeing this illness hit younger adults. And we know that's true in sickle cell disease, that those patients' disease seems to get worse with age. And when we look at our utilization data and our pain utilization data nationally, the curve looks remarkably similar. So we don't know, and someday if we're able to get more epidemiological studies that help us with that denominator of, no COVID, COVID, and the population at large, that would be great. But we don't actually even have a good registry of all patients with sickle cell disease across even the United States. So that is a difficult thing to think about, but hopefully that's something we can do with administrative data, most likely going forward.
Dr. Geddes, are there any educational resources you can share that you found helpful having to do more distance learning?
I think there's been discussions of how to make the big problem with remote learning being that it's not as interactive. So discussions of using things like the flipped classroom. There's also been talk among the APPD about there's a kind of a weekly webinar that they conduct to talk about different ways to improve fellow education in this remote setting, and kind of out of the box ideas like maybe even people having access to teaching that's happening at other institutions through the magic of remote learning. So I think this will be a constantly evolving area, but there are groups like APPD that are trying to, and ASPHO, that are trying to optimize this.
Thank you. Just a couple of notes. If we do run out of time, if we can't get to all the questions, we'll complete responses to the questions and send to the attendees later. And some of our speakers are trying to answer some of the questions in the question box as well. Dr. Panapinto, do you know of increased findings of thrombosis in patients with sickle cell disease who presented with severe or moderate presentation? You're on mute. That's right.
Very good question. So as many may remember, or maybe not, when we first heard about COVID in March, and as we built the registry, thrombosis actually was not being thought about. And so we didn't put that on the case report form, but we have since pivoted to add that as a data capture field in the registry. So we hope to have some of that data moving forward. And we wonder if some of those sudden deaths perhaps could be related to clotting, which is now being widely described in the literature. So.
Along those same lines, do you have any experience with the prophylactic anticoagulation in the COVID positive patients, and whether you are continuing prophylaxis after discharge?
Yes, so that's also some information we're collecting in the registry. But in addition, as we think about these patients who are hospitalized, at least most of the children's hospitals around the US have, and adult hospitals too, have prevention of venous thromboembolism protocols that they follow for high-risk patients. So, for example, a patient I was taking care of met that criteria for prevention of thrombosis treatment. And so that varies by your hospital, but for our hospital, that was using Lovenox twice a day. So I think that was despite any COVID-specific recommendations. So I think those are being recommended across the country. In addition, many have started, many of the physicians that specialize in clotting on our team have shared that there's some NHLBI guidelines for COVID and clotting and treatment, whether it's prevention or treatment of clotting. In addition to the American Society of Hematology is assembling a guideline panel to address COVID and treatment and prevention of clots.
Dr. Panepinto, looks like there's another one for you. In regards to the sickle cell patients that died, what was the age range? More likely to be adult patients versus pediatric?
Yes, great question. So we've only had one reported death in a child. All of the rest of the deaths have occurred in adults.
Are you using Clexane, C-L-E-X-A-N-E, to treat all the symptomatic ones? Is anybody using that medication at all? Okay. Thank you for the great talks. Question for Dr. Panepinto. From the registry data, is there an indication of increased COVID-related mortality in the sickle cell disease population? So similar lines to the last question.
Right. I think, unfortunately, yes, we have not seen the death rate drop below, 8 to 10%. Again, understanding the data may be skewed, but this is really quite high when we look at what's being reported, not only for the US as a whole, but other countries across the world. And I think I like to compare it to the inflammatory bowel only because that registry was also started around the same time as ours. And that mortality rate was more like 4%, so those with a chronic disease. And I don't know if that's a fair comparison to compare sickle cell disease to inflammatory bowel, so it'll be helpful as we gain more information in other diseases, if it's the presence of the chronic disease, or as was alluded to by Dr. Kung, if there's something about other illnesses where immunosuppressive medication is being used that might actually be protective in this illness.
Comment please on the pediatric stem cell transplant recipients. Are they at any greater risk either during the peri-transplant period or post-transplant period? Is there any risk associated with those with more severe GVHD, especially those on steroids or tacrolimus? Dr. Kung, do you have any experience at Sloan Kettering, or have you seen any of this? Do you aware of any of the data?
I think we've been very careful in terms of testing prior to initiation of transplant and have not taken a patient with active disease into transplant to speak to that piece. I would say our experience in terms of following not only our pediatric but also the adult side has not suggested that there is increased risk beyond the general population. As for GVHD, I think we just don't have the numbers to address that specifically.
Are the panelists bringing patients with common diagnoses that we follow, such as neutropenia, anemia, and routine sickle cell patients in for lab work?
So for general hematology and sickle cell disease, we have tried to limit exposure to the health system as much as possible. And so for sickle cell disease, for example, for hydroxyurea labs, we have spaced those labs out if we're not, and we're actually not changing doses of hydroxyurea to prevent any inability to sort of monitor response to that. And so we are going more like 4 to 6 months without labs and without changing dose.
Does anybody else on the panel want to take on that question? Okay. Could the panel give us an update on vaccine status?
Soon, I hope. I have no idea, but crossing my fingers.
Okay. Does positive COVID patients with mild symptoms or even asymptomatic prevent them from taking chemotherapy? So I think we addressed that one a little bit before about chemotherapy practices. Speaking of vaccines, does anyone have any thoughts about whether our on-treatment oncology patients will even be eligible to receive a vaccine if one becomes available? I'm thinking it will need to be tested further in patients with acquired immune deficiencies. Are we looking only to vaccinate those around them? Herd effect. I think this will probably have to be our last question for today. So if anybody wants to answer this, the rest of them will have to complete responses and send to the attendees later. Got a lot of questions, so thank you so much for sending all the questions. Dr. Kung, do you want to take on the vaccine question for our patients?
Well, I mean, I think as people are aware, there are multiple different types of vaccines in development right now, and so what type of vaccine and its safety profile, I think, will ultimately dictate who's eligible for it. As a transplanter, obviously, we would worry a lot in terms of live attenuated vaccines, but none of the current leads in terms of vaccines for COVID-19 are live attenuated. So I think the devil will be in the details.
All right, well, thank you again to our esteemed panelists, to all of the attendees. Thank you for sending all of your wonderful questions in. I'm sorry that we were not able to get to them all, but again, we will respond to the questions and send the answers later. And thank you to the ASPHO staff for helping put this together. This webinar was recorded and will be available on the ASPHO website. Please remember to go to www.aspho.org to access the ASPHO COVID-19 resource page and the ASPHO member community. And please stay tuned for the ASPHO Virtual Research Showcase series later this summer, featuring some of the top-rated science accepted for this year's ASPHO conference. Thank you again for attending.